Good afternoon. I'm Beth Battaglino, CEO of Helping Women, and I'm so happy to welcome you to today's webinar, Heart to Heart, How Pregnancy Can Affect Your Heart Health Throughout Your Life. As both the CEO of the nation's leading independent health information source for women, and as a practicing nurse in maternal child health, I know firsthand the importance of today's topic. So many women think of heart health as a man's issue, yet that couldn't be further from the truth. In fact, heart disease is the leading killer of women in the United States during pregnancy and throughout life. These facts highlighted that more education is needed on women and heart health, and in particular, the effects of pregnancy on heart health throughout your life. Today's conversation is a step in the right direction, and why we've assembled such an esteemed panel of experts, including today's moderator. A good friend to Healthy Women and mine, Dr. Nieca Goldberg, is a practicing cardiologist and a nationally recognized pioneer in women's heart health. She is the medical director of Atria New York City, a clinical associate professor at NYU Grossman School of Medicine, and a former medical director of the Joan H. Tisch Center for Women's Health at NYU Langone Medical Center. Dr. Goldberg is also the co-medical director of the 92nd Street Y Cardio Rehab Program, a host on Dr. Radio Sirius XM 81 of Beyond the Heart, author of various articles, research papers, and books, including the award-winning Women Are Not Small Men, and a national spokesperson for the American Heart Association, where she started the Go Red for Women campaign. We are so lucky to have her today. Before I turn it over to Dr. Goldberg, I want to thank Amgen, Bristol Myers Squibb, and Novartis for their support of this important program. And of course, our partners at the American Medical Women's Association, the Preeclampsia Foundation, and the Preventative Cardiovascular Nurses Association. Thank you so much, Dr. Goldberg, and welcome.
Thank you, Beth. I'm honored to be part of this important conversation. And it's especially important that we have this discussion now, because over the last year, surveys done by the American Heart Association showed that there's been a 20% decrease in awareness of cardiovascular risk, of women taking it as a personal risk factor. And that is something that's disturbing, because it seems that the awareness has gone down in women under 50, and particularly in women of color. So I think focusing today on potential clues to heart disease risk in pregnancy can help give younger women some more information so that they can take action to reduce their cardiovascular risk.
I couldn't agree more. And I'm so glad that you're here to moderate this important conversation.
Thank you. And it's a privilege to introduce today's panelists. I'm going to introduce Dr. Erin Poe-Ferrante, who's Assistant Professor of Nursing and an Adjunct Professor of Nutrition at Emory University in Atlanta, Georgia. She's also Fellow in the American Academy of Nursing, the American Heart Association, and the Preventive Cardiovascular Nurses Association. Dr. Ferrante's clinical expertise is as a public health nurse and diabetes prevention and management educator. She is also a certified diabetes care and education specialist. Dr. Icilma Fergus is Associate Professor of Medicine and Director of Cardiovascular Disparities at the Icahn School of Medicine at Mount Sinai. Prior to that, she served as Chief of the Division of Cardiology at Harlem Hospital Center here in New York. And Dr. Fergus focuses on areas related to preventive cardiology and health equity. Dr. Emily Jones is an Associate Professor of Nursing at the University of Oklahoma College of Nursing and is licensed as a registered nurse and has maintained clinical certification in inpatient obstetrics. She's a very valuable person to have on this discussion in this discussion of pregnancy. Dr. Jones holds fellow status in the American Heart Association and the Preventive Cardiovascular Nurses Association for her expertise in the intersection of women's reproductive and cardiometabolic health. Dr. Judette Louis is chair of the Department of OBGYN at University of South Florida. She is specialist in maternal fetal medicine and serves as immediate past president for the Society of Maternal Fetal Medicine. Dr. Louis has a joint faculty appointment in both the College of Public Health and College of Medicine at UCSF, and her research in obstructive sleep apnea in pregnant women led to a career focused on maternal mortality and morbidity. Dr. Louis has been a champion of studying health inequity and inclusion of pregnant people in clinical trials. And I look forward to discussing more of that with you, Dr. Louis. Also joining us today is Debora Grandison, a 32-year survivor of heart disease, diabetes, and Graves' disease. Debora was trained as a champion for Women Heart, the National Coalition for Women with Heart Disease. She serves as a speaker and educator for the American Heart Association and was selected as a Go Red for Women Real Woman national spokesperson in 2019. Debora is also founder of She Speaks from a Joyful Heart, and indeed she does. And I want to thank all of you for joining us. We're going to kick things off with Debora, who will share her journey. Debora.
Thank you, Dr. Goldberg, and thank you, Healthy Women, for this opportunity to share my story with you today. My heart journey began 32 years ago after going into preterm labor in the second trimester of my second pregnancy. The medication that I was given to stop the preterm labor tripled my heart rate, and I ended up in the ICU. During that time, the doctors worked to stabilize my heart, and they came up with two potential diagnoses, one being mitral valve prolapse. And I was treated as a mitral valve prolapse patient for the next 20 years. Now, I spent an extended time in the hospital as they worked to try to stabilize everything. And I then was sent home to be on bed rest for 3 months before my son was born. And then I would make weekly visits to the hospital to be monitored to make sure that he was doing well as myself. It was then that I was then diagnosed with gestational diabetes. Now, actually, that happened prior to the preterm labor. And at that time, I was placed on insulin. Now, I was told all of the risks that were potentially possible for losing the baby, and then also the long-term risks of living with diabetes, such as blindness, amputation, kidney disease, but not once was heart disease connected, or that wasn't something that it was spoken of until later on. So I didn't know the risks of diabetes and heart disease at that point in time. I continued to be treated as a mitral valve prolapse patient, as I said, for the next 20 years. And in 1995, we moved to another state. I will say that in 89, my son was born. I had a healthy baby boy, but I was strongly urged to understand the risks of possibly trying to have another baby. And we went on to get second and third opinions on that. But we made the decision that we wouldn't make the attempt. So we moved to another state. And of course, a new state meant new doctors. And I searched for a doctor that would help, or a team actually, of a diabetic doctor as well as a heart doctor that would help to manage my care. And it was quite challenging to find the perfect fit for quite some time. Now, in that move, I began to experience a number of symptoms I started having extreme heart palpitations, shortness of breath, dizziness, and arm pain in my left side, my left arm. All, of course, which are symptoms and factors of heart attack. So I would find myself being rushed to the ER quite a few times. And then also I went through a numerous amount of testing. I wore Holter monitors. I had chemical and treadmill stress tests, and I had a number of cardiac catheterizations as well. All while not ever having any changes in the diagnoses. I was still being treated with medicine for the mitral valve prolapse. I was even given 13 different medications at one point by a physician who was treating every symptom that I was having, but never addressing any of the root causes. All those medications caused me to function poorly. I was a young mother. I was a full-time employee. I was a wife. And it became very challenging for me to manage all of these things in my present state. So I then experienced, in the middle of all of that, I had to give up my job. And in all of the frenzy and frustration, I also lost 3 immediate family members to diabetic-related heart issues, including my brother, who was 35, who suffered a massive heart attack and passed away. It was then that I began to believe that I too would suffer the same fate, and I began to live like I was going to. So I then had my last catheterization done, where they were checking to make sure there were no blockages. And it was then that I found a doctor who told me that he was a plumber and I may possibly need an electrician. I had no idea that there was such a thing as electrical issues of the heart. So I went to this new physician, and I was then diagnosed with cardiomyopathy. And I was told that my heart rate was continuing to go down and that I may potentially be faced with having to have a pacemaker put in. I did have a pacemaker put in 2009. After having the pacemaker installed, I regained my energy, my faith increased, and I began to get my life back. I started getting involved with a number of health advocacy organizations, such as were mentioned, American Heart Association and Women Heart. And I began to do that in support and to encourage other women who may potentially find themselves walking in similar shoes. I also began writing words of encouragement to myself and then passing those words off to others. So I formed the LLC, She Speaks from a Joyful Heart. The mission there is to support and empower and encourage others to find their joy in the midst of their challenges and their struggles. And I continue the mission of advocacy and awareness of both heart disease and diabetes. I want to thank you so much for allowing me to have this opportunity to share a portion of my story with you. And now I'm going to turn things back over to our moderator, Dr. Goldberg.
Thank you so much for sharing that, Deborah. And, I want to clarify things so our audience can understand before I bring the other panelists in. It sounds like you went through an ordeal before you got a diagnosis, which is not uncommon amongst many of the women I see in practice and probably Dr. Fergus sees in practice. So I want to understand, you had a diagnosis of mitral valve prolapse, but that was never proven. Is that
exactly?
Okay.
That is correct. I was treated with the medication that you would give a mitral valve patient. And back at that time, you even had to take your antibiotics when you go to the dentist. I did all of that for 20 years.
Yeah. And then the other term that you mentioned was cardiomyopathy, which is a heart muscle issue. And did they think this cardiomyopathy occurred during your pregnancy?
That was never determined, actually. I mean, like I said, they treated me for the mitral valve, which was not the correct diagnosis. And that wasn't discovered until 2008 that I had cardiomyopathy.
And then you pointed out,
I'm
right.
sorry.
Then you pointed out an even more important, you encompass the cardiovascular symptom. First, they thought you had a valve problem, then they talked to you about a muscle problem, and in the end, you had an electrical problem where they needed to speed up your heartbeat.
Absolutely. Yes. Yes,
And I'm
ma'am.
going to bring in Dr. Fergus because I have a question. This highlights what is cardiovascular disease, because it comes in all different flavors, doesn't it, Icy?
Yes. Good afternoon again. That is such an important question. And I think that really understanding what cardiovascular disease is would kind of help to bring some context into what Debora was talking about. So thank you so much, Dr. Goldberg, for that question. So simply put, anything that affects the heart or vascular system that may lead to dysfunction or malregulation of cardiac function is cardiovascular disease. And it's a very broad topic, but let me try to put it into context by using an analogy. So think of the heart as a pump station that has 4 rooms, walls, plumbing, electricity, and entrances. So the walls are the walls of the heart, and any dysfunction in that can reflect a cardiomyopathy. Any dysfunction related to the entrances or the valves can lead to issues related to volume of blood and even irregular heartbeats. So Deborah had a mitral valve prolapse, which is something that she could have been born with, or it's something that could have developed over time with wear and tear and redundancy of the valves. You also have plumbing, right? So when you talk about plumbing of this pump station, the analogy within the heart are the vessels of the heart, the vessels that supply the coronaries, as well as vessels that, supply your entire body. So you'll have arteries and you have veins. And all of this is related to the heart, as the heart pumps blood through the arteries and the veins bring things back. So a blockage in these vessels may lead to something such as a heart attack that we all think about. And Deborah also mentioned that she had an electrical malfunction or dysfunction. So again, thinking of this 4-room pump station with electricity not working, this would be an electrophysiological dysfunction, because yes, our hearts work, by having electrical signals that tells the heart to beat. And a normal sinus rhythm, the heart's beating regularly between 60 to 100 beats per minute. But you can have dysregulation with either a slow heart rate called bradycardia or rapid heart rate called tachycardia. And then within all of these, there's either irregular or regular types of, functions. So you could lead to things like SVT, atrial fibrillation, etc. And then finally, also involving the walls of the heart or the outside of the walls. A lot of young women get this. It's called pericarditis. So that's like the outside shell or the sac that surrounds the heart that could become inflamed. So all of these different dysregulations of all of these systems, again, valvular disease, the chambers, the vessels, electrophysiological dysfunction can lead to any of these dysfunctions that may result in an arrhythmia, heart attack, heart failure, myo or pericarditis, valvular disease, or cardiomyopathy, as Deborah just talked about. So I hope that's helpful.
I think that's extremely helpful, because I think when most people think about heart disease, or when someone says cardiovascular disease, they immediately think about a heart attack.
Yes.
But the heart has, as you said, rooms and walls and an electrical system and a plumbing system, and disorders can occur in either part of the heart or in multiple parts of the heart.
Yes.
So it's really important that when you go into the doctor because you suspect that you have heart symptoms, that you make sure your doctor is listening to you and that you have a conversation. And in particular, I think one of the most important questions a patient can ask is, what do you think is causing this? Because you want to direct the conversation in your medical visit into the underlying problem and how we can best take care of it. And it should be a shared decision between the woman and her healthcare provider. And with that said, I'm going to bring in Dr. Judette Louis. And I had the privilege of speaking with Dr. Louis last week on Dr. Radio, and it was a great conversation. And I want to talk to you about, if you ask you to discuss some of the health concerns during pregnancy that could be related to heart health, either during the pregnancy or later on in life.
Absolutely. One of the things that we have recognized is that pregnancy could be considered a stress test, that there's a lot of changes that happen within your body that puts the body under more stress. And so what we're finding is that sometimes pregnancy could be the first time that your body shows signs of heart disease, whether it be something like cardiomyopathy or hypertension. Sometimes that's the first time we see it. For a large portion of patients, that disease may go away, or at least it appears it goes away after you give birth. But what we know is that individuals who develop these conditions in pregnancy show a higher rate of developing heart disease later in life, and that on average it happens about 5 to 10 years earlier than people who never had those conditions. And so, to be clear, the conditions I'm talking about during pregnancy are things like preeclampsia, hypertension in pregnancy, cardiomyopathy, or even just gestational diabetes. All of those predispose you to heart disease later in life.
That's right. And even in recent articles, they looked at preterm birth or preterm labor as one of the contributors to midlife heart disease in women. And we need to find the best way that we can get women followed, because I'm going to bring Dr. Ferrante into the conversation now. As a clinician and a scientist, we know that blood sugar and diabetes can greatly affect pregnancy. Can you explain to us what is gestational diabetes?
Yes. So gestational diabetes is diabetes that's first picked up in pregnancy. I'm sure a lot of women remember that sometime between 24 and 28 weeks of gestation, you get to take a glucose liquid, and they'll check your blood sugar to see. It's basically a screening test to see if your blood sugar is high. Like Dr. Louis said, pregnancy does serve as a stress test. And so we know during pregnancy that the insulin needs to maintain glucose in a woman's body goes up by about 3 times. And so pregnancy is naturally an insulin resistant state. But for those women who are not utilizing glucose as easily as other women, those glucose levels will go up, and you may have gestational diabetes. If you fail that first screening test, then you come back for another test. And if you're, if your blood sugar is high on that second round, then we do diagnose you with gestational diabetes during that, with that.
Yeah, and I want to, just to continue that conversation, I want to bring in Dr. Emily Jones, because I want to talk to you about, and I want you to share with our audience, and before you answer my question, I want to remind our audience, they should feel free to send in questions through the chat box, and we'll answer them. Our panelists will answer them during the program. So Emily, I want to talk to you about how having gestational diabetes can affect the chances of developing diabetes or cardiovascular disease later in life.
Thank you for that question, Dr. Goldberg. This is an area of research where there's actually been a lot of studies just in the last 10 years to help us better understand women's risk after having gestational diabetes in pregnancy. And here's what we know. we know that women who had gestational diabetes have a 7 to 12-fold lifetime risk for developing type 2 diabetes down the road. And they have a 20 to 50% chance of developing diabetes in the 5 to 10 years after that pregnancy with gestational diabetes. So that is not somewhere way off in the future in 2 or 3 decades later. That's 5 to 10 years later. So this is a woman who will still have young kids in the home and probably not be thinking about chronic disease unless someone has provided that level of education and done something to help increase awareness and perception. Now, there's been a lot more study about a woman's risk for developing diabetes after gestational diabetes than there has been focus on cardiovascular disease after diabetes. But this is another area where there's a lot of research happening in a short period of time, just in the last 10 years or so. And there was a big study that was conducted in the last year or two. It's called a meta-analysis, and it's where they pool a lot of data from many studies. So there were 9 different studies represented in this meta-analysis, and that represented like over 5.3 million women. And what this study found is that women who had gestational diabetes had a 2-fold higher risk of cardiovascular events after their pregnancy compared with women who did not have gestational diabetes. Now, here's what's really interesting to a lot of clinicians and researchers and women, I would guess. That risk for having cardiovascular events or disease later on was not dependent upon developing diabetes between GDM and the CVD. So what we know is women who have gestational diabetes are at risk for developing cardiovascular disease with or without developing diabetes, type 2 diabetes along the way. Therefore, they are a very at-risk population who we should be thinking about in terms of preventing cardiovascular disease after pregnancy.
Yeah, and I wanted to just follow up that is that we and as a clinician, that women come back after they have their baby 6 weeks later to see the obstetrician, and then they fall off the radar of the healthcare system probably till menopause when they want to get checked out again.
Yeah, that's correct. And also it brings to mind a paper that Dr. Ferranti and I wrote together with a colleague of ours a few years ago, where we actually looked at the postpartum follow-up rates of women who had gestational diabetes and hypertensive disorders in pregnancy. And we found that really only about 40% of women, the general population of women overall in the US, actually do show up to that 6-week postpartum visit. And if you look more closely at that 40%, they're overrepresented by women who are well-resourced and generally white women who have private insurance. And so we see that there's health disparities buried in these follow-up rates as well.
Very important point. Now, I have a question for Dr. Louis, and this is from our audience. Is there a certain onset timing of preeclampsia that further increases lifetime cardiovascular risk, or is the risk the same no matter when the onset?
That's an excellent question, and one that, in fact, there have been studies to look at. If you have had preeclampsia, which required a preterm delivery, your risk is higher than if you develop preeclampsia at a full-term gestation. The risk is highest for those who have preeclampsia, particularly in what we call the second trimester. So, those are people who typically will have it between 20 to 28 weeks of pregnancy. The other characteristic that is more strongly associated with the risk is if the baby had other complications such as growth restriction, which we think is a marker of how severe the preeclampsia was. Also, if you have recurrent preeclampsia, so those individuals who have it in almost every pregnancy, they seem to have the highest risk too.
Yeah, I think this is all very important. That was an excellent question. And I want to bring Dr. Fergus back into the conversation, Icy, because we're talking a lot about, conditions that it can affect heart disease. But I know sometimes when women are pregnant, there are normal changes that occur due to the cardiovascular system that get them kind of concerned. So let's go through that. How does pregnancy affect your heart and circulatory system?
Certainly, and that is an extremely important question. But first, let me just say I was, really, I would like to support what was previously just presented, because I see those patients in my office years after having, or not so many years after having their pregnancies. They're coming in with elevated blood pressures, with elevated blood sugars. And when you do assessments, cardiac assessments, you're already beginning to see that their effects on your heart in terms of either enlargement or this diastolic dysfunction or other things like that. But normally, what happens to your body during pregnancy? I went all the way back, and there's been data on this some way back when. I reference a paper by Metcalf that was presented in 1974, and that's I think people paid a lot of attention beginning back then, recognizing their changes. And from a hemodynamic standpoint, the most important change that occurs in the maternal circulation during pregnancy is that there's an increase in cardiac output. In the average woman, cardiac output at rest rises 30 to 40% above her non-pregnant resting value. First, most of the increment occurs early in pregnancy and has already reached its highest levels halfway through gestation, about 20 to 24 weeks. And a second important point is that the cardiac output of the resting pregnant woman fluctuates markedly with changes in her body position. So supine position can cause the cardiac output to fall from levels observed when the subject is sitting down or lying on her side. And the other thing that happens is that cardiac output decreases in the final trimester. So if someone's having hypertension that is significant, like preeclampsia, that leads, that increases cardiac workload, and there are issues already with cardiac output going up, people can have, heart failure, issues with the cardiomyopathy, et cetera. If they have underlying valvular issues, you could see that these fluxes in cardiac output can lead to issues in terms of having, again, arrhythmias, volume overload, or other difficulties that are a result of some of these things we're talking about, like preeclampsia and gestational diabetes, even immediately. And I just want to comment that weight gain in pregnant women increases the workload on the body. So from any physical activity. So the additional weight and gravity slow down the circulation of blood and bodily fluids, particularly in the lower limbs, leading to edema. So again, if you gain too much weight and now you're having these fluxes in cardiac output, et cetera, that can also lead to significant issues that, would cause, not so good outcomes for the women.
Yeah, and that's for what can happen when people have potentially underlying heart conditions, and how it puts increased stress on the system when they were stable and then they become pregnant. But there are certain normal changes in the heart function that we expect during pregnancy. For instance, in the first several months, blood pressure goes down. So it's not unusual to have women come in and be concerned that they have low blood pressure. Mm-hmm. And also the criteria for high blood pressure is in a lower range in pregnancy. Mm-hmm. Yes. One of the other, some of the other things that come in that I've seen in the office is there's an increase in palpitations, but not like in Debora's case. They come and go and don't send you to the ICU, and that's expected because of the fluctuation in hormones. Correct. And during the latter part of pregnancy, and I'll bring Erin in this, that women can have, Dr. Ferrante, that women can have edema and swelling. But the really important point is knowing when that needs to be evaluated.
Yeah, so certainly if it's accompanied by other symptoms, or, you've you already are diagnosed with hypertension or already diagnosed with gestational diabetes, that definitely needs to be looked at. It can be one of the early signs of progressing hypertension and potentially preeclampsia. So it is something to talk to your provider about for sure.
Yeah, and there is a question, Dr. Ferrante, I want you to answer that just came in. Being that obesity is a national health crisis, how is this further impacting women during pregnancy and their heart health during and after pregnancy? And as a public health nurse,
yes,
I think you have a lot to say about this.
I do. Probably not enough on this time, but yeah, obesity is a national crisis. We do know that. And we certainly know that obesity puts people, even non-pregnant people, at higher risk for type 2 diabetes. So the rates of gestational diabetes in pregnancy reflect the baseline rates of type 2 diabetes in non-pregnant persons. And so coming into pregnancy, overweight and obese certainly puts you at higher risk because that extra weight needs that additional insulin. And if you're struggling with gestational diabetes, your body is not responding to the insulin or not making enough insulin. So yes, additional weight is very challenging. And yeah, that's it.
Well, I'm going to bring another nurse in to answer this question, I think, because somebody with a nursing background this question comes up a lot. And I'm Dr. Emily Jones. My OB never brought up my gestational diabetes after delivering. Should I mention it or should bring it up with another doctor? If so, can I ask my primary care provider or do I need to see a specialist? That's a great question.
That is a fabulous question. And I'm so glad this person is listening to this webinar today. I would say to the person who asked this question, I'm really sorry that no one on your team, your provider, your physician, if it was a physician or midwife or nurse, no one mentioned this to you in terms of the long-term and ongoing risk that gestational diabetes represents. To answer your question, yes, please do bring this up. It's absolutely appropriate for you to bring this up to your primary care provider. And in fact, in the last 5 years or so, all of the major provider associations like the American College of Obstetrics and Gynecologists and even some of the primary care provider associations have been trying to get the word out in their professional guidelines to get providers to ask this screening question. So I really hope that within the next few years, we will normalize the question of asking every woman who shows up to a primary care appointment, have you had any conditions that were diagnosed during pregnancy, like preterm labor or preeclampsia or gestational diabetes or increased blood pressure during pregnancy? But if they're not asking you that question, you should definitely feel empowered to share that information and ask what their guidelines or what their advice is for you in terms of best ways to take action to reduce your risk.
And I want to just point out, Emily, isn't this a good way to use the electronic health record? Get a complete history for all to see so the healthcare providers can connect the dots, because usually the issue is a failure to connect the dots.
Absolutely. And this is another thing that we recognize is a real problem in our healthcare system, because a lot of electronic health records don't talk to other records. And so there's this loss of the story. And so that's why we still ask women to tell their story, because we can't rely on a system that's going to be there to provide that full story.
Yeah, Debora, do you want to talk about this failure to connect the dots? You're representing patients today.
Yes, I would. As a matter of fact, I am still wearing an insulin pump. I've been diagnosed as a type 1, and I'm hoping maybe one of the physicians can maybe speak on that, because I'm hearing type 2. How rare is it that you would be given a type 1 diagnosis? Another thing that I'd like to bring up, if I may, really quickly, is when my daughter was born 2 years prior, she was born early, and the doctor that I was seeing, I had moved to another state then, said not to eat sugar because the baby might die. And that's all that I got. But because I got that information when I was pregnant with my son, I had the wherewithal to tell them, my new doctors, that conversation had started, and they did the gestational test early. So that's why I'm such an advocate, because we've got to be listening, and we've got to advocate for ourselves. And you may have to piecemeal, like you're saying, put that puzzle together yourself in some instances when you're going in to see a physician.
You really have to be your own advocate.
Yes.
We have another really interesting question, and I'm going to ask Dr. Louis to answer this. The question is, if you had preeclampsia and chose not to have another pregnancy, is your risk less than if you had 2 pregnancies with preeclampsia?
Yes, the risk is slightly less because, when we try to figure out why we see this association, one of the theories is that you were predisposed to have the disease anyway. Another theory is that that pregnancy and preeclampsia itself actually works towards accelerating your heart disease. It's hard to know which one it is as the pathway, or maybe it's a little bit of both. So if you chose to not have another pregnancy, you're kind of in between, because you could have been the person who would have had another pregnancy and not had preeclampsia, or you could have had preeclampsia, but we just would never know. So what we see is that if you have one prior episode of preeclampsia, you have a 2-fold risk. The people who have recurrent episodes have about a 4-fold risk. So somewhere in between there.
Yeah, and Dr. Fergus, do you have any additional comments for the person who asked the question?
Yeah, I agree with exactly what Dr. Louis says. And as she says, sometimes there are some genetic predispositions, or, maybe some socioeconomic predispositions as to why people may be more prone to having, elevated blood pressures. And so certainly that's already there, but you've heard the risk. It increases if you're going to have recurrent pregnancies where your blood pressure is going up. And sometimes you can go straight from preeclampsia to eclampsia, which is a pretty tough situation. So certainly, I would certainly heed the risk of the advice of your OB if you're trying to get pregnant again. And in my practice, Dr. Goldberg, they would partner with a cardiologist, and and then we would do things like we'll do echoes throughout, and really sort of monitor the patient for volume overload, and ensuring that they're on the appropriate medications that are not teratogenic, because there are multiple medications that you could use for high blood pressure, but many of them are not to be taken while you're pregnant. They're not indicated, and in fact, they may be teratogenic. So important to partner, in this case with maybe a cardiologist, or at least your primary doctor, if you're having issues such as these.
You bring up an important point that is important for lots of conditions, but Erin, I want to bring you in, Dr. Ferrante, the whole concept of a healthcare team, particularly in someone who has preeclampsia or hypertension of pregnancy, and how important it is to have the nucleus of providers that communicate well together, to all work to bring about a healthy delivery and postpartum care.
Oh, yes. Thank you for that question. It's so important. And traditionally in our healthcare system, we haven't always done a great job of partnering across specialties. But I think the recognition of the need for that in pregnancy, particularly, obviously the OB is following the pregnant woman, but when there are issues that come up, such as hypertension or diabetes, it really is necessary to partner with the cardiologist or with the endocrinologist, who can help monitor that pregnancy, and then certainly be a referral source when that pregnancy is over, because as has been said already, we know women are at increased risk for developing type 2 diabetes and chronic hypertension when they've had these conditions during pregnancy.
And, oftentimes in practice, when I'm taking a history on a woman and she could be 50 years old, she's not pregnant, but I go back and ask her all those questions about what happened in terms of her health earlier in her life to try to get an understanding of where the risk started. And we have another, we're getting great questions from our audience. And this audience member writes, I was on fertility treatments for years and finally got pregnant. Blood pressure went up near the end and had an emergency C-section at almost 36 weeks. Anything I should be flagging for my primary? It was never discussed during my postpartum visit. Dr. Emily Jones.
So very similar to my response to the question about flagging this for the primary after gestational diabetes, same answer for the same reason. Yes, because officially this would be considered hypertension during pregnancy, even if it didn't show up early on. There was a reason that it showed up, and it may not be known. Back to Debora's point about the root cause. So it's very worthwhile to bring up that experience to your primary care provider, and even share that you attended this webinar, and that's when you got the idea to bring it up, and see where it goes from there. And ask that question that we encouraged others to ask earlier, which is, why do you think this might have happened?
That's right. And I think that if you think it's not right, then ask the question, because you are the best judge of your health. And another audience member writes, if my mother or sister had heart issues or diabetes during their pregnancy, does that mean I'm at greater risk? Is it tied to family history or race, ethnicity, or both? And I'm going to ask Dr. Fergus to answer that question.
Absolutely. I think that's an excellent question. And certainly there's race and genetics, but also socioeconomics and your particular cultural situation that actually increases the risk of having some of the similar outcomes between family members. So having hypertension, it is, you're predisposed to that in families, and certain types of heart disease, et cetera. So if your family members have that, then I would say come in prepared, as far as ensuring that you have baseline assessments, that your blood pressures are checked preceding. And if you have a particularly high risk where there was a poor outcome, like a heart attack or some other thing, then you may want to have initial testing such as an EKG and maybe even an echo. And when it comes to race and ethnicity, and I think that maybe this was going to be a question coming up for me later, and I don't want to jump.
No, that's fine. You can do it now.
Okay. So again, and I think that was alluded to earlier in your opening statement, Dr. Goldberg, that we're seeing more issues as it relates to communities of color. And part of that may be, related to less awareness over this time during the pandemic. But if I were to say compare Black women in general, they're 3 to 4 times more likely to die from a pregnancy-related cause than white women. And this comes from the Centers for Disease Control and Prevention. And actually, they state that it's partly why the overall rate of pregnancy-related deaths has climbed in the past 2 decades, making maternal mortality rate in the United States the worst in any industrialized country, according to a 2016 analysis published in The Lancet. So, and the reason is that there may be comorbidities that may exist in, certain communities. So there are cardiometabolic risk factors already maybe underlying, propensity for having elevated blood pressure, pre-diabetes. They may have early elevated A1C. You may also, we talked about weight, but also lack of access to, to certain, educational information early treatment. But I do want to point out that there's maybe more than just social background, because you all may be aware of that. I just wanted to give two examples. People may be familiar with Serena Williams and Beyonce. So in those cases, there are no socioeconomic issues. That Serena Williams is one of the best tennis players of all time. She's very physically active all the time and working out, exercising, etc. And Beyonce, as you know, she's a singer. But in 2019, they both shared similar stories. Each experienced life-threatening complications during their pregnancies. Serena Williams actually developed a pulmonary embolus, or DV or clot, which can happen post pregnancy. And in Beyonce's case, she had twins, and she had preeclampsia. So again, there's more to it than just simply socioeconomics. There's genetics involved, but I would say if you're at risk, and if you know that your family is at risk, then starting earlier and getting, baseline assessment would be very helpful, and hopefully would, alleviate these outcomes.
That's well said. And Dr. Louis, I want to bring the conversation back to where we started and talk about preeclampsia. Do race or ethnicity play a role in preeclampsia? And what are some of the risks for preeclampsia?
Yes, so we know risk factors include a familial predisposition, first-time pregnancy. Another risk factor is your age. If you are young, very young at the time of pregnancy, or if you are advanced maternal age, those are risk factors. There are some modifiable risk factors, such as obesity is a risk factor. And then there are risk factors that are related to your underlying health conditions, such as if you have pre-existing high blood pressure or pre-existing diabetes or kidney disease. When it comes to the role of race, we do see that a certain populations do have a higher rate of preeclampsia. That includes Black women, as well as American Indian and Alaskan Native women. The question as to why they have it is still under a lot of investigation. That some of that association you see goes away when you account for other health factors that are believed to be in part related to some of the structural racism that is in place. It's related to them not having access to the right nutrition and higher rates of obesity and chronic conditions. And when you take those pieces away, the chronic health conditions and the chronic stress, there appears to be less of an association. And because we know also that race is not a genetic thing, it's a social construct.
That's right.
And so you have to look at all of the other social things that are contributing to that difference. One of the things I did want to point out as patients are listening to us, and I'm so glad we're getting these great questions and people can now go advocate for themselves. I would like to point you to patient information on the Preeclampsia Foundation website, that we have handouts that are made just for the patient. And I say we as if it's me, it's not me, it's them. But, but there are handouts that you can take and bring to your healthcare provider to advocate for yourself, because if they've never heard of it, it's easier for them to blow you off, than if you hand them an infographic that comes from the site that shows, 2 to 4 times risk of heart disease. So that's just the other piece I wanted to throw in there.
I think that's very good information. And I want to also look at regarding Emily, regarding your work and research. Can you discuss why it's so important to develop lifestyle interventions that are culturally relevant and what it means for women?
Sure. Thank you for that question. And I think it's not just culturally relevant, but situationally relevant, right? Because these are young women, for the most part, who are leading very busy lives. So in my research and others' research, we've found over and over that it's this issue of competing priorities and demands. And women always take care of others first, it seems. That's the default mode. And so part of the struggle is to design an intervention that can actually be useful. It can be accessible to a woman to incorporate into her daily life that will help her reduce risk factors. And of course, I think we tend to go straight to things like, okay, I need to eat a healthier diet, low fat, watch my calories, watch my carbs. Sometimes those things come to mind first, and physical activity comes to mind. And yes, those are extremely important. But what we find is sometimes stress gets in the way of doing those things that can actually help us reduce what we call cardiometabolic risk, or our risk for developing diabetes and heart disease. So one of the areas of my research now that is getting more attention across, I think, the nation is this issue of how does stress impact young women? How does stress play a role in not just disease development, but the ability to do things on a daily basis to reduce our risk? And so that's another thing. Sleep is a huge issue that also needs a lot of attention. And so if you think it's just you and you're struggling with getting enough sleep and it's just a part of life, I think you should bring sleep up to your provider too, because we know that impacts our cardiometabolic health in huge ways.
Right. Sleep is a vital sign. And we only have a couple of minutes left, so I'm going to pose a question to Erin and then Debora. If you had a magic wand and you can do one thing to improve awareness leading to young women taking care of their hearts, what would you recommend?
Ooh, just one thing. That's hard, but I think educating yourself, being on webinars like this, learning as much as you can, and certainly being an advocate for yourself and those that you care about. There's nobody, that knows your body like you do. And if you think there's something wrong, there probably is, and it's worth bringing up.
Yeah. And Debora? What
Same
would
question?
Yeah, same question.
Okay. Well, of course, I'm going to piggyback off of what Erin said. And in these 32 years, having to, like I said, piecemeal things together. Knowledge is power. You've got to make yourself knowledgeable about those things. It's really about your team. You want to have a great rapport with that team, the medical team, because you're going to be relying on them, but you advocating for yourself, number one, and going in with the right information, the right questions, so you can get the right answers.
Absolutely. And on behalf of Healthy Women, I want to thank all of you for participating today. And once again, thank you to Amgen, Bristol Myers Squibb, and Novartis for their support of today's webinar. For more information on women's heart health and how pregnancy can affect your health throughout your life, please visit healthywomen.org. It was a pleasure to spend this time with all of you today.
Thank you.
Bye.
Bye, ladies.